Hello, everyone. Welcome to my show, The American Enterprising Americans. And this show is all about the biggest challenges Americans face in this country. And we are going to do a series of videos on topics related to healthcare. And in the healthcare continuum or medical care continuum in US, there are multiple P's, as we call it as. First, the P starts with product, which is a pharmaceutical product. It could be a diagnostic product. It could be a device which goes into a patient's heart, or over-the-counter medications. These are the P's for the product. Then you have physicians or providers, we call it as, who write prescriptions. And then there are pharmacies where we buy medications. And then there are group practices, hospitals, nursing homes, and hospices. These are all the providers. And then we have payers, like the insurance companies, which provide health insurance. We covered that topic last week. And this week, we're going to cover the providers. It could be doctors, or it could be nursing homes, testing facilities, and all that. These topics are very, very critical now with this pandemic going on in the country and across the globe. So this is an educational video which will give my viewers an understanding on how healthcare systems work in this country. And now I would like to invite Jerry Rhoads, who is an author, expert on healthcare, and he was an entrepreneur. He ran his own companies, and then he is an expert on this area. I would like to welcome my speaker today, or my host, or my guest today, Jerry, and I would like to take his opinion on on this topic. Jerry, hold on. I'm trying to get you on the video. Okay, I see you now. Thank you, Jerry, for joining my call as usual. Please introduce yourself.
My name is Jerry Rhoads. I'm a CPA. I'm a licensed administrator for healthcare facilities. I've been in the healthcare field for 50-some years. Started out with Arthur Andersen in the day, and one of our clients was Blue Cross. And Blue Cross was the primary health insurance company in the country. And they had an organization called Blue Cross of America, and Arthur Andersen, that was an Arthur Andersen client. So we then were assigned with the project to go out and help roll out Medicare. And this was in the late 1960s. It got passed in 64, and we took our assignment to do this in 1968. And I was a part of the team that started going out to the providers, principally hospitals at that point in time, to try to prepare them for what was expected from them with respect to their costs, and also talk about billing. And when I got to the hospitals, they didn't want to talk about anything except billing. And we started to find out that they didn't have any cost systems other than these primitive cost reports they'd been submitting to Blue Cross for a number of years. So it was a little discouraging when you found out that they weren't even tracking census. And with respect to the physicians, they were even more behind the times, since they had never had to bill the government. It's usually Blue Cross. And so my experience then from that point on was to try to help everybody develop some knowledge and expertise in not only how to bill it and collect it, but also how to price their services, which is still under scrutiny, and then deal with the government when it comes to denial of claims. So I'll give you a little bit of a background.
Thank you, Jerry, for the nice introduction. And so we will come, I know the healthcare industry, or rather healthcare continuum, if you will, for lack of a better word, has full of problems and loopholes. We'll come into those. But I would like to start the question. I would like to start, getting your opinion with a question, saying that if you last week when we spoke about how health insurance covers different type of people in in the country. Let's talk about, okay, so I have a student, and the student has a health insurance and he's not feeling well in this COVID situation. Where does he start and how does it go? Right from, let's assume that a student, actually, I would like to give you an example. One of my one of my intern who works for me till last week, she is coming from Indiana University. She was supposed to go back to college this week. On Friday, she met with a friend of hers and her dad for dinner, and then the dad now is positive for COVID, and she's really scared, and she is in Indiana University, and she now has to go through this continuum of providers. Now, please walk me through how does she navigate the system? What happens? That will be a great example for you to walk us through.
So you want me to take her through the entire continuum
Continuum.
of care?
Yes.
Okay. Well, the first step is that she has to have a physician. And presuming that her parents have a physician, she's probably using that physician. And the physicians anymore typically belong to a group, and that group then is in partnership with another group, which would be the hospital, the independent hospital, or maybe a part of a corporate chain. And so she has to then get an appointment, of course, and she might want to go to a testing center because the physicians, they're not doing the testing. It's outside of their really. They're there to take care of the patient that has been tested positive and is having an active uh, episode. So that has to take place, and then it gets into the referral process. Is then the physician then determines on an office visit, I would imagine, because that's what we're encouraging if you have symptoms, and then recommend a hospital where the physician is going to do some blood tests, I would imagine. If she's got a temperature and she's got body aches and that sort of thing, he may even consider admitting her to a hospital. But if he does not, he's probably going to order some medications to try to use therapeutic means rather than admit her to the hospital. And then she's instructed that if it gets any worse, then either call him or go to the emergency room. And then when she gets to the emergency room, she then has to start signing in the what we're going to call a continuum of care. The hospital will decide whether they're going to admit her or not. And if they do admit her, then they inform the physician that admission has taken place, and then they will not override the physician's medications. They will accept those and then start the process. If she's critical, she'll go to ICU. If not, she'll maybe stay in the emergency room for a few hours just to see what's developing. And then if she is admitted, they will then have to interview her either in the room they assign her to or in the emergency room to get her insurance information and her, start developing the record keeping that the physician has already done. And in some instances, if the physician is a part of the group that's a part of the hospital group, they may have electronic transmission of those of her medical history. And if they do, then they don't have to redo that, but they are going to have to make sure she's got insurance. If she does not have insurance, that her parents have insurance, or that she has Obamacare, which would be provided by the insurance company. And then once she's in the hospital, they have to do the thing. And if she does have active COVID, she's going to be there for a while. I would imagine, but she's younger, so she's probably going to uh, be medicated and then get some kind of respiratory services and then return home. And
Okay.
if she returns home, they can provide her with home care.
Right.
That's another provider. If she's not well, uh, then she can go to a long-term care facility. But typically, if she has COVID, that's not recommended because the nursing home is not going to be able to provide her with the respiratory services that it requires to restore her. But if she does get referred to a long-term care rehab center, which is something higher level than a nursing home, then she will also then have to have her insurance checked to see if she has coverage for that. And if she was an elderly patient or if her parents were one of the patients, they're not going to be for, hopefully now that it's proven that the nursing home shouldn't be a place to send them, they will have to convalesce in the hospital.
Mm. Oh, wow. This sounds very, very complicated. Now, let me come to the issues which I have a lot of questions in this. So first of all, when this person goes to a primary doctor, assuming that her parents are covering her for the insurance, some of the tests, let's say she goes to a doctor says, okay, based on the symptoms you're showing, I think you have COVID. Why don't you go and get it tested in one of the labs like Quest Diagnostics? And then what if her coverage doesn't cover the whole labs? Who pays for it and how does that work? Can you please explain that?
Well, how old is this person? Is she under 26?
Yes, she is definitely under 26. She is maybe
Well, then
21.
her parents have insurance and they're going to cover the lab testing. They may have a copay to pay, depending upon who the underwriter insurance. And then the billing will be done by the lab to her insurance provider. And she will then, her parents would probably cover the co-insurance.
Hmm.
And then she's in the system, at least. But the older you get and the more critical the COVID is, the more the continuum will get involved. Because there's a point in time where the nursing home, a skilled nursing home, can get a referral, so long as it isn't, if the pneumonia or viral pneumonia or COVID has been not resolved, but at least reduced to a level that they can provide skilled nursing services, then she would go to a skilled nursing facility. She would also have to have, her parents would have to have some coverage for that referral.
Right.
And it would have to be their private insurance that would pay privately for that stay.
But tell me, the COVID testing, I believe, are free, isn't it?
Yes, it is.
Okay. So if,
Well, in most states it is, as far as I know, it is throughout the country.
and then what happens to, okay, now assuming that she is sent for the COVID testing, luckily for that will be covered because of the federal government mandate. Now, what happens to the hospital once that if a person is diagnosed with COVID and he gets into a hospital, is that covered currently under the COVID program or no?
No, it's covered by the health insurance, by our
Okay.
health insurance company.
What
I
if
mean,
those people
there's
don't have?
some 30 different healthcare companies, so
Right.
whatever our company is, they're going to cover it, less the whatever copay they have after a certain amount of days in the hospital.
Right. I was actually bumping into recently I bumped into one of the person who worked for Quest Diagnostics in the past, leading company who was doing testing. And I was shocked to learn from him that they are doing testing, but they don't know who will pay for it. That's an interesting scenario at this point. They are just doing testing. They have still not figured out whether is it going to be states will be paying, or is it the federal government or the individuals. But anyways, the point I'm asking is, luckily this person has insurance. What if those people who don't have insurance, who will cover for that, even
Well,
if they have COVID?
that's interesting that they don't seem to know who they should. The provider doesn't know who to send the bill to.
Right.
They know how to send bills before they know how to admit a patient. I mean, they're more concerned about that than anything.
Right.
But if she doesn't have insurance, again, Obamacare, she has to have been able to cover her deductible, or even the physician won't see her. And those deductibles are quite high. Now, you know, if she's under 26, that she can be covered under her parents' policy.
Mm-hmm.
But if her parents can't cover her, then there is Medicaid, which is if she doesn't have an Obamacare policy and she's what they call indigent, she would be then covered by Medicaid as an adult.
Mm.
And that the requirements for that is that she would they have to seek approval.
Right.
If she hasn't already filed for it and gotten a number, a Medicaid approval, and they would have to file, the hospital would have to file for approval.
Right.
That's when it starts to drag out.
Right. Because the approval takes a long time, and that's where it drags out, right?
Yeah, and then there's other coverages for if she's under 18. There's some children coverage for her.
Right.
Again, she has to apply for
that. Now, the question I have is, okay, this is a younger, individual. What if there is an older individual who's already in nursing home, for example?
Okay.
And how does that scenario change in that case?
Well, while they're in the nursing home, they're categorized by payor type. Who's going to pay the bill? Private pay, they're responsible for it privately. That's room and board and supplies and whatever they're charging for the nursing services and therapies. But private pay typically will apply for Medicare first. So if they're in a nursing home and they've been sent to the nursing home from the hospital, and they had a 3-day stay, then they can apply for Medicare inpatient coverage under Part A for up to 100 days. And the first 20 days is without copay. They call it it's free for the first 20 days. Medicare covers everything. After that, Medicare will pay a certain portion, and then the patient has to pay the rest. And typically that would be a copay of $179 a day, which they then have a supplementary policy, hopefully, that would pay that. And so then if the provider keeps them on Medicare for the full 100 days to recuperate and be restored, then the patient would not be responsible for any of that costs. It would be covered by their primary insurance company and the supplementary. But if they have a Part C policy, which is managed by the insurance company, say the provider is Aetna, then they have a comprehensive policy which covers the stay in the nursing home, but then they have to pay a copay after 20 days of the $176 a day for that, which they have a supplement.
Now, let me ask you, this is an interesting equation in this whole continuum. What if somebody is an Iraqi war veteran or an Afghan veteran? How does that work for veterans in this case?
If you're have a green card, you mean, or you're in country?
Yeah, obviously, I'm looking at veterans who participated in the war, or rather went to war on behalf of US, is obviously citizens. So in case if they are citizens and they happen to be veterans, how does that work?
For COVID?
Yeah, COVID or any let's say they have any mental health issue because of the war or whatever the condition is, do they go to the regular hospitals or do they have special facilities?
No, they'd be covered by the Veterans Administration insurance. That comes, if they're older, Medicare comes after the VA contract expires. And they do what they call a secondary payor source when you're going to a nursing home, because they're not going to bill Medicare unless that the patient's exhausted other options, other insurances, which could be, again, um, a private insurance company covering them. But if they're citizens, then they're treated just like anyone else. But if they're veterans, then they go into the Veteran Administration, which would typically be one of their hospitals. And then once they have been discharged from that hospital, they can refer them over to a skilled nursing facility who then can bill additionally for some Medicare coverage. It
But
might be
so the
Part
question,
A or
right?
might be Part B. From there, once they're into the continuum, if they want to go back home, they would be discharged from the skilled nursing facility into a home care program, which Medicare does have benefits for that, for the skilled nursing and the therapy part,
But
for up to 100 visits per year.
I was under the impression, this is great actually what you're saying, because I was always under the impression that veterans, because they fought for us, they should not have any limit to their healthcare costs, because they left their families, sacrificed for the country. They lost a limb or they lost they lost both their legs in the war, and they come in. So are we now saying that they also have a limit and beyond that they will not be covered? That's not right as a country.
Well, the hospital is going to want to discharge them to some long-term care facility or rehab facility, and they will continue to cover. I'm not saying they don't. And Medicare will not pay if the VA is continuing to pay. And
Mhm.
they do continue to pay after they're out of the hospital. They'll
Right,
pay for physician service. They'll pay for nursing home services. That nursing home has to be contracted with the VA to be certified to provide those services. So they may not have a choice of who to see and where to go.
I see.
That's one of the problems.
Mm.
But we and the problem with VA is that they were very particular about who they contracted, and
Right,
so it was difficult to get certified for VA, and which made it very difficult to get paid,
right,
because we had to collect whatever other benefits they had, so we could take that out of what we were going to charge, such as if they had disability or Social Security check or something like that, and we had to coordinate that whole billing process with whatever they were coming to us
right.
with, and if they didn't have anything, then they have availability of Medicaid uh, uh, if they have no other alternative.
Right, right. Okay, so
And there's no limit on the Medicaid.
sorry, go ahead. Your voice was breaking. Can you say that again?
And yeah, there isn't any limit to what Medicaid will pay for their stay if it's medically necessary.
Right, right. If it's medically necessary, there is no
And
limit. Okay,
so the criteria with their family.
right. Now let's
But
pivot
VA
to,
is going to cover them through the whole process until they no longer qualify for VA coverage.
right, right. So let's pivot towards a different question I always had. Now, if you look at the continuum, so you have an older patient, for example, they have other underlying conditions like a diabetes or obesity or whatever, and they are now affected by COVID. Now, and then they go to a hospital. A hospital turns them down, and they send them back to the nursing home. And then, so the interesting fact is, as you know, majority of the people who died in US are a lot of them are from the nursing homes. So what could be some of the factors which lead to those deaths, which is very alarming number of deaths?
We have to review the rules because unfortunately in New York they didn't have anybody that they were consulting with that even knew what skilled nursing facilities can do these days and have someone pay them for them. They are not allowed to have ventilators. They have to qualify and certify and have 24-hour coverage by respiratory therapists and RNs.
Hmm.
And, and Medicare will not pay just any nursing home when they get a referral for even a viral pneumonia case. They're not supposed to discharge viral pneumonia back to the nursing home unless they have been stabilized to the point where they don't need a respirator or they don't need a ventilator, and they can be taken care of by the nursing staff. And they have the nursing home will have a contract with a respiratory therapist, but they certainly don't have them on staff full time. Now, in
Hmm.
the 80s, we used to be able to set up vent units in skilled nursing, and it was abused. And so it got to the point where skilled nursing homes don't have vent units
Hmm.
because Medicare wouldn't pay for it. And so the
How,
difficulty is that continuum should have been known in New York City and all over the country, that if they have viral pneumonia, they're a hospital patient, not a nursing home patient.
right. Now, what do you mean by abuse of ventilators? What do you mean by abuse of ventilators?
Well, Medicare pays for ventilator services on the basis of, like I said, having a full-time respiratory therapist and having a full-time RN available to monitor and manage the case. Under a typical Part A Medicare patient, that's an add-on.
Right.
You get a higher rate, and most Medicare rates are set by what they call RVUs, relative value units, and it's an average amount per day, not considering the complications of COVID and respiratory, and because you can have breathing equipment, but not advanced to the ventilator.
Hmm.
So you're going to have to get approval for an add-on to what you would generally get, because the RVUs there's 66 different levels of care in that rate, and it's all pretty much focused on maintenance, not um, critical care.
Right.
That's the hospital's business. And the problem, the hospitals don't want them back. They want them out in a certain amount of time because they get cut off by Medicare after a certain length of stay there. They can get an outlier and probably do for COVID, but typically, for a stroke, they get paid for 4.5 days, and they send them back to the nursing home.
Hmm.
Because if they keep them longer than that, they lose money. If they get them out sooner, they make money.
Right.
So they're paid on a DRG, diagnosis-related average rate, depending upon that grouping that they're in. So we're not seeing pricing on the basis of an episode or for a level of care. It's on the basis of codes. And
Right.
that's one of the biggest problems I have, is they're paid for input, not output.
Right.
They're paid for income, not outcome.
Right.
And they're sending the patients to the nursing homes too early. They aren't equipped to do that. And this is, generally speaking, this isn't just COVID.
Right.
And they're expected to provide them almost subacute care
Right.
for skilled nursing rates. And what we had to do, of course, is we had to set up special units and get them to pay us more for taking higher level patients. So
Mm.
you had to, outside the cost reporting system that they had, which is antiquated, you had to get specials or you couldn't afford to admit those kind of patients. And then that also applies to obesity, which is complicated by diabetes. Those have to be special units, and you have to have special pricing, or
Mm.
you can't afford to staff it and provide what they need. And so right now we're not at a point where we price things by episode, and the providers being required to provide cost accounting systems that can track that episode from the physician to the hospital to the skilled nursing home uh, to the hospice to home care.
Mm.
We don't have that connection, and the information and the terminologies are different. It's not standardized.
Right.
And in my books, I make a big issue of the fact that we need to start standardizing and these episodes and flows using artificial intelligence systems, which my son and I developed to be able to um, forecast out based upon not just diagnosis, but on the basis of their health systems that are being um, uh, deficient or at risk, and do these models of care on the basis of health systems, not the 77,000 diagnosis codes that they're using.
Right.
But this hasn't reached the point where everybody is going to have to be accountable for their costs
Right.
and support why the prices are so high.
So
Uh,
are
there's
we
no
saying, so in that case, are we saying the historical abuses and historical inefficiencies in the system is one of the contributing factor for so many deaths in the nursing homes?
I I think it's you can make that case. Uh, I think that there's always been a problem between the nursing home business, so to speak, or industry, that their rates are not based upon their costs.
Mm.
And there is no cost accounting system being required by the government other than a cost report. And those cost reports are annual, and they're always 2 years old by the time they start impacting the rates. And this is true of Medicare and Medicaid and even private insurance, as they're using these averaging systems from antiquated cost reports to develop these DRGs, that's diagnosis related groups.
Mm.
It's 469 different rates that they will pay a hospital for an average length of stay. But it has no relationship to what it's costing the hospital to provide the care and how many days it really should take to get that referral to the next level of care, which is typically a skilled nursing facility or an outpatient service or home care.
Right.
The hospitals have been in and out of the business of owning nursing homes and then divesting of them or having a skilled unit in the hospital, trying to configure this so they can figure out, how the government's going to pay for this. But payment has always been the biggest problem. And it's all, we think we're going to get cured or we will get better or we'll go home. And what do we get? We get a code.
Right.
And we have no idea what that $50,000 bill, along with the pricing that they've attached to that, really doesn't have any relationship to their cost, represents. And so at the hospital, it's the DRG, it's the nursing home, it's the the RUG, and if the physician's relative value units, it's on how long they spent with the patient on each encounter.
Right.
All averages.
Mm.
And my definition of averages is that you have this guy that puts his bare foot in a bucket of scalding hot water, right foot, and the left foot goes into a bucket of ice cold water, and on average, he should feel great.
Hmm.
Well, know, at either extremes, it isn't great.
Right.
And that's the problem with the entire system, is we don't have what you'd have in a business,
Right.
is that you would have a process that people go through and encounter, and whatever is labor and materials and equipment and whatever would be used to cost that episode through the service from the hospital. And they would refer it to the nursing home. They'd pick up the ball, so to speak, the care plan. This is all called a care plan or a treatment plan. And then they would have their cost absorption system to continue with that modeling. The models can be developed where you can estimate on the basis of prior experience and have it forecasting out on the basis of what's happening with that body system and the problems that are related to it, the services that are going to have to be provided. They're called interventions.
Right.
And then the interventions would be attached to what the expectations are for recovery or rehabilitation or restoring the patient, using, again, the models to track this all the way through the continuum to the point where they are at their lowest level of care at the lowest amount of cost. And as you know, as I've discussed with you, my son and I developed such a system, but the government at this point is just not requiring that they produce cost per episode.
Right.
At any level of care. And so the consumer doesn't pay the bill, so they're not concerned. The insurance company better pay it. Well, they don't always pay it. They deny claims because it isn't medically necessary or you don't need it or whatever. So there's this dichotomy in the system, and has been there since I got involved in 1961, and Blue Cross said they would pay for everything. You just file a one-page cost report and they'll pay you that plus a 6% add-on for profit. This is what they were telling hospitals. And then Medicare came in and we had a whole different system, but it was still based on these annual cost reports and a settlement at the end of the year. Then they went, because that wasn't working out, the costs were going up 16% a year. So they decided they wanted to have prospective costing, which means that these prices, as they call them, would be set on the basis of diagnosis and encounters by physicians and the number of days in a nursing home, all of them on an averaging basis. But
so what you're essentially saying is that we need to change the way we measure the outcomes rather than incomes. So I think that is I think what we should do is, in our next talk, I think I will put together a kind of a PowerPoint slide for our viewers, because if you compare two different models, so the current model versus what you are recommending, if we list out those things, it'll be much more clear in terms of in a very simple way where the problem is, because this cost of the healthcare is becoming a major election issue. I think that would be a really educational for our viewers.
The first step, Karthik, is that we have to get the realization that the individual is going to have to start being a consumer, because until that happens, there's no one to hold the providers accountable for whatever costs they got,
right,
and whatever price they set. It's just between the provider and the insurance company, or right, Medicare and Medicaid.
Right.
And that's right now 16 to 20% of our GNP is going for health care services. And now we're being told that it's going to be a right, not a privilege, which further says the patient doesn't have any response to staying healthy. And when they don't stay healthy, the cost will skyrocket.
Right.
And as we all age, then we're going to be absorbing. Right now, chronic disease absorbs 80% of our healthcare dollars.
Right.
And there's 117 million that have designated chronic disease codes. And that is eating up 80% of the healthcare dollar. And actually, it's not all the aging people that this is happening to. It is younger and younger people that are not healthy. They're obese. They have diabetes, they have heart problems because of smoking, and all of that is that. Right. It's not now all of the elderly.
Right.
But the COVID has struck the elderly, and 80% of the deaths been in the nursing home. So we
Right.
should have focused our resources, whatever was needed, there, not on the general public.
Right.
And we're still making that mistake, is that we're scaring everybody to death on the basis of the risk being less than 1% for your general population,
Right.
including children, including teachers, including everyone.
Right.
And so personally, we ran nursing homes, and every year the flu was going to take all of our patients. That's what we were concerned about. I guess I got a battery problem. But
So
anyway,
let me
I'll
ask
drop it.
you. Let me pivot towards a different question. Now, you brought a very good point on, consumer being a stakeholder in this whole game, meaning if he also has to pay from his pocket, that will be kind of a deterrent for people, getting sick or trying to be as healthy as possible. So one interesting fact is, I would like you to comment on it. If you look at the number of deaths in US compared to South Asian countries like in India or, Thailand, Malaysia, the number of people who are dying per thousand because of the COVID is much higher in US compared to the rest of the people. So it tells me two things. One is that immunity levels of people living in US is lower compared to the rest of the world, maybe because of the food habits or whatever, or the exercise regime, or there's something else going on. What is your take on it from a immunity standpoint?
Well, I read you the statistics. 65% of people don't exercise at all, and 40% don't read the labels, and 25% they're costing us all a lot of money. So, it's habits, it's lifestyle, it's this whole factor of that. It's economists say until you internalize something, you don't care about it. And we're not internalizing staying healthy. We've externalized the whole responsibility because we say it's a right.
That's a good comment. That's a great comment.
Government's responsibility. I have a right to health care.
Right.
You have a right to health care if you stay healthy.
Right.
I'll agree with that. But if you're not, guess what? As we get older, the young people are going to pay for all of that.
Right.
Because they're no longer earning any money.
Right.
So don't let anybody tell you that, Medicare is going to pay everything. They're not.
They're not. Right. Right.
The younger people are going to pay. And that's what happened in Obamacare, is that when the reality hit them that if you get an Obamacare, you got to pay your deductible or a doctor won't take you.
Right.
Hospital won't take you.
Right.
And that was $5,000. So it was very difficult to get a doctor or get the hospital to admit.
Right. So the other question I have observation was that recently there was a viral video which went online of a doctor in Florida. He's a doctor within the emergency care unit, and he was telling that an exercise called proning for those people who are having COVID, like you bend and make sure that lower part of the lungs get enough air circulation, because that is where I believe COVID impacts. And then he said that he recommended everybody taking a combination, a concoction of a ginger, turmeric, and honey. He says that these are the three things which also will help you kind of a medication. Do you think food, I know that we take, Americans eat a lot of outside food and, but do you think the ingredients which we eat also make a difference in terms of improving immunity, and maybe we should educate people on what are the things they need to include as part of their diet?
Well, I think one thing that would get their attention, and I think, yes, it does have a big impact, is test people's immune system. If these immunologists are such experts on telling us that we have to bend the curve, why aren't they? And because there are tests and there are ways of improving your immunity. And we're not being told that. Right now, rather than chasing a vaccine that we haven't been able to find for 100 years, waiting on that, we should be doing something about the immune system.
Right.
Because if the immune system has been compromised, that makes you high risk. You know, the rest of us who are not at risk because our immune system has not been compromised, that shouldn't be the focus. We have to start focusing and testing, if we're going to test anything, people's immune system. Well, with a blood test, they'll come back and tell you your cholesterol is too high. Therefore, your immune system has to work too hard, and cholesterol is really a good thing unless it has to work too hard and it's too much of it. Well, we're not schooled in that sort of things. The doctors are not into prevention, and we have to, in these sessions, talk about the fact that all this money is spent on treatment.
Right.
It is not spent on prevention.
Right.
And so we're suffering from that. America in general is not healthy. And the reason we're going to have more deaths per thousand is that we have an unhealthy population. And it's getting less healthy and older. So we got the double whammy there.
Right.
How in the world can we continue to not have prevention when a pound of prevention is worth, you know, in money, a dollar spent there is worth, well, the World Health Organization says we save 75% of our healthcare costs.
Right.
If we were investing it in prevention.
Right.
Well, right now it's an aspirin in the emergency room and a mammogram.
Right.
We are not paying and have not structured a system that pays for outcome. It isn't there. There is no definition at any one of these provider levels as to what the outcome that they're pursuing and how they're going to pursue it.
Right.
And I spent 40 years of my career developing software that would enable them to do that.
Mm.
And until the government tells them they're not going to pay the bill unless they can prove their costs, this whole thing is never going to get solved. I don't care if you're Obama, Biden, or Trump. Until we do that, this whole system is going to take us down.
Right.
Both health-wise and economy-wise. And it's showing up. You know, I don't have to stress too much. The reason that we have this continuing problem of everybody being scared to death is that we do not have a country that has built a healthcare system to preserve health, first of all, by using natural remedies, not just pills.
Right.
Because those pills don't cure anything. They mask it if nothing else. And all of them had side effects. And I hate these ads on TV from these insurance, or these, I'm not going to criticize Abbott because I know you work for some, but these fancy little names, they got a company that is a marketing company that develops these names to sell prescription drugs.
Right.
Okay, is that the solution?
So
it's a part of this.
That's a very, very good comment you made. We have there was one gentleman who was visiting US and he went back to India and he was in a TV show. He's a very reputed individual. I don't want to take his name, but he made a comment saying that when he was visiting US for about 6 months, he went all over the country lecturing. He's a very famous man, and in the hotel or in the homes where he used to live, when he switched on TVs, he said 90% to 80 to 90% of the advertisements are either by the healthcare companies or pharma companies, and rest of them are either car companies and all that. And then what he was saying was, it seems that 60 to 70% of people in America take drugs, prescription medication, and the rest of the people are on illegal drugs. He was saying that looks like that's the trend, because I don't see any other advertisements in the television channels. That it's a very funny comment, but looks like that is what is going on in this country.
Well, now we have some politicians who want to legalize drugs,
right?
Not just drugs, and I suppose that's for a different podcast. But no, I am really stressing that we need to develop preventive healthcare, and with these AI models,
right,
artificial intelligence models, we can build preventive care plans and preventive healthcare plans on the basis of everybody has the same body systems. We
Right.
all have the same system. You think an automobile mechanic is going to check everything? No, he's going to check a certain system on the basis of what the symptom is. In healthcare, we jump from symptom to diagnosis.
Right. Okay, I think I lost my Jerry, and then I'll have to regroup. Let's continue this discussion, viewers. It's a very interesting topic. I'll have to get Jerry on board again. Okay, Jerry, you're back. Thank you for some reason, I think technical difficulties made us get out, and now we're coming back. Okay, so I think we need to cover this topic in a little more detail. What I would like to cover is two or three things. One is that how do we what is ailing the current system versus what you're recommending as a new system, which means that for the viewers who don't have any background on how this whole thing works, I would like to put a PowerPoint slide comparing both models so that they can quickly understand it, number one. Number two, I would like to also talk about prevention and what are some of the things they need to do for improving immunity and prevention. And the third thing I would also like to cover in the next topic would be that what do we need to do? There are three things. One is physical health and mental health and prevention. And the fourth and the important thing is food. What do we do to improve, educate people on eating the right stuff? I think that would be one of the key criteria. Jay, are you there? So I think
Yeah.
that would be the topic we'll cover on the next time, next in the podcast or in the next video. It was great talking to you, Jerry, as always, and I would like to leverage your expertise in this area. But this is a never-ending topic for you, I know. But I would like to take more of your expertise in this area. We'll cover a series. We'll make series of videos on this. This is more education.
Okay. Okay.
I really appreciate your time, Jerry. Thank you very much for your time. As always, I enjoy talking to you and learning from you on a day. Every time when I meet you, it's a great education for me.
Well, thanks for giving me the opportunity. You asked very good questions.
Thank you. Because I am just, sometimes my questions are dumb. Please pardon me because I'm not expert in this area.
No, I mean, they're real questions. It's about real people. It's not theory.
Right. Right. Okay.
I mean, we can get all kinds of bad theory if you from the internet. Really cool to agree. Like I said to you before, I think that's a major hurdle. It's not just the government. It's not just the providers. And it's not just the consumers.
Right. Right.
The consumers now are in the dark. They are in the dark.
Right. So
the providers are just trying to make ends meet, pretend like and seeing this topic with the top university professors.
Right.
And I was the only one from private sector.
Right.
So I'll open up with that story, and then we can kind of put that in context to what we're up against.
Right. Thank you, Jerry. Have a great night.
You're welcome. You too.
Okay.
Take care.
Bye.
Bye.